Okay, bersama saya kembali Zaimi daripada zaimi.com. Hari ini kita akan melalui 3 topik mengenai buah pinggang ini, itu urinalysis, renal stones dan renal function test, clearance test. First, through urinalysis. Okay, renal dysfunction. Lecture 2. The urinary system. This is the part of component of urinary system: renal tree, renal vein, aorta, inferior vena cava. The kidney produce urine. Okay, then the ureter transports urine. It produce here, then transport to urinary bladder, stores urine. Then urethra passes urine to outside. Then we go to the morphology of kidney. Renal pyramid, renal medulla, this one, renal medulla, renal cortex, nephron, this is small one, we call it pinggang. This is nephron. The renal pelvis, ureters, and grass anatomy. You can see the glomerular capsule, afferent arteriole. Let's go through here. Then next to venial, arteriole, renal artery, renal vein, venial, proximal convoluted tubule, distal convoluted tubule, glomerulus is inside tubule, the renal cortex, renal medulla, collecting duct. You can see here the stopper section. Descending limb, capillaries. Urine is produced by the kidney to maintain constant plasma osmotic concentration, to regulate pH, electrolyte and fluid balances, to excrete some 50 grams of waste solid, mostly urea and sodium chloride. Some normal urine constituent is excreted in gram 24 hours. Urea 25 to 30, uric acid 0.6 to 0.7, creatinine 1 to 1.2, uric acid 0.7, ammonia 0.7, ammonia acid 3, sodium chloride 1 to 15, potassium 2 to 4, calcium 0.2 to 0.3, magnesium 0.1, chloride 7, phosphate 1.7 to 2.5, sulfate 1.8 to 2.5. What is urinalysis? Urinalysis is the analysis of urine, and one of the oldest laboratory procedures in the practice of medicine. It's a good test for assessing the overall health of a patient. It provides information about the state of the kidney and urinary tract, metabolic or systemic in kidney disorders. Urinalysis can reveal diseases that have gone unnoticed because they do not produce striking signs or symptoms. Examples include diabetes mellitus, various forms of kidney failure, and chronic urinary tract infection. So, review of kidney function. The composition of urine, approximately 96% water and 4% dissolved substance derived from food or waste product of metabolism. The actual composition of urine varies depending on diet, metabolism, general health of the body, and health of the kidney. Urinalysis is performed to assess the urine's composition as well as kidney function. Record the urinary system consists of 2 kidney and 2 ureters, and the bladder. Also recall the role of blood to nutrients and oxygen to cell of the body and to carry waste material away from the cells. The kidney has the largest role in controlling the chemical composition of the blood in order to maintain proper cell function in the body. In the kidney, blood undergoes filtration and dialysis to separate waste compounds that will be removed from the body from those that will return to the circulating blood. That with waste, the renal will clean the blood and waste to the bladder, the urine product. More specifically, the kidney has the function of removal of waste products from the blood, retention of nutrients such as proteins and glucose, maintenance of acid-base balance, regulation of water and electrolyte salt content of the body, hormone synthesis. Urine is formed in the kidney structure called the nephron. This is the nephron. This kidney contains about 1 million nephron. The nephron is made up of a glomerulus and set of tubules. The tubular portion of the nephron consists of several structures. This is the proximal convoluted tubule, loop of Helm, distal convoluted tubule, this one, and collecting duct. Urine is formed through a three-phase process of filtration, reabsorption, and secretion. Distribution of the blood occurs between the specialized collection of capillaries in the glomerulus. The glomerulus contains small molecules and ions from the blood current to a surrounding tubule called the Bowman's capsule. This is called the filtrate. Blood cells and large protein molecules remain in the blood and return to the venous circulation. The absorption of essential chemicals, the body needs glucose, amino acids, and sodium chloride, and other salts, water, and vitamins occur in the nephron proximal tubule, loop of Helm, and distal tubule. The absorption prevents the loss of necessary body compounds, but also adjusts the concentration of the urine, so it is more dilute when the body has more water, more hydrated, and more concentrated when the body is short of water or dehydrated. The secretion of foreign chemicals. The body does not need ammonia drugs. The hormonal toxins begin in the proximal tubules and continues in the distal tubule in the collecting duct. Secretion of excess ions such as hydrogen and K, potassium, help to establish electrolyte and acid-base balance. All three processes of filtration, reabsorption, and secretion occur simultaneously as a result of complex cellular transport mechanism and buffering mechanism with the nephron tubules. The glomerular filtrate becomes more concentrated, and immediately after it leaves the distal tubule and enters the collecting duct. The fluids that leave the collecting duct is now urine. The process of glomerular filtration and renal tubular distribution and secretion can become affected when the kidney is compromised by disease. Loss of renal function can be caused by a variety of conditions such as meningitis, heart failure, injury to glomerulus or tubules caused by drugs, heavy metals and viral infections, and diabetes, hypertension, and kidney stones. Urine analysis used to screen for the cause and the extent of renal dysfunction helps detect substance of pseudo material in the urine associated with different metabolic and kidney disorders, reveals diseases that have gone unnoticed because they do not produce striking signs or symptoms. For example, diabetes mellitus, various form of glomerulonephritis, and chronic urinary tract infection. Often substances such as protein or glucose will begin to appear in the urine before patients are aware that they may have a problem. In patients with acute or chronic conditions such as kidney disease, the urine may be ordered at intervals as a rapid method to help monitor organ function, status, and response to treatment. This is a method of urine collection. We have 5 methods. Random collection taken at any time of day. The specimen is dilute, isotonic, or hypertonic, may contain white cells, bacteria, and squamous epithelium as contaminants. It contains vaginal contaminants such as trichomonads, yeast, and Giermann's red cells in females. Only morning collection of the sample before ingestion of any fluid. Hypertonic inflates ability of the kidney to concentrate urine during dehydration, which occur overnight. If all fluid ingestion has been avoided since 6 p.m., the previous day. A specific grade usually exceeds 1.022 in healthy individuals. Number 3. Clean cache or mixture urine specimen collected after cleansing the external uterus. Get a sponge soaked with benzalkonium hydrochloride, useful and non-irritating. Mixture urine is one in which the first half of the bladder urine is started. The collection vessel is introduced into the urinary stream to catch the last half. The first of the stream serves to flush containing cell. A microbe from the up to urethra before collection. This is easy, but it is not. Before catheterization of the bladder through the urethra for urine collection is carried out only in special circumstances, such as in a comatose or confused patient. This procedure risks introducing infection and traumatizing the urethra and bladder, thus producing iatrogenic infection or hematuria. Number 5 is suprapubic trans-abdominal needle aspiration of the bladder. When done under ideal condition, this provides the purest sample of bladder urine. This is good method for infants and small children. Routine analysis is composed of 3 examinations: microscopic exam, chemical test for abnormal chemical constituents, and microscopic exam for abnormal insoluble constituent or sediment. Microscopic exam. You can see a 3 urine sample. This is red color for the appearance, red color but clear, yellow but cloudy. Appearance of normal: fresh urine, 3. Time of day after fluid intake, concentrated for early morning, but to dark yellow or amber in color and clear. Common urine volume 750 to 2000 mL per 24 hours. Turbidity or cloudiness may be caused by excessive cellular. Bacteria or protein in the urine may develop from crystallization or precipitation of such upon standing at room temperature in the refrigerator. Becomes clear after addition of small amount of acid, indicating that precipitation of such in the bubble cause turbidity. Red or red brown abnormal color could be from food dye. Eating fresh beets, drug the presence of either hemoglobin or myoglobin. If the sample contains many red blood cells, will be cloudy as well as red. But yellow color be the first indicator that the patient has concentrated hepatitis B, probably due to bilirubin produced because of obstruction within the liver. Bilirubin normally being excreted into the gut. From the left to right, straw clear, yellow hazy. Yellow clear, red orange, brown hazy. The volume in temperature climates, a normal adult will excrete 100 ml to 2500 ml of urine per day. Reduced urine output with free access to dietary liquids indicates renal dysfunction. Increased volume may indicate diabetes or a failure of the kidneys to respond to antidiuretic hormone produced by the pituitary, which regulates water absorption or damage by kidney stones. Urea is volume less than 300 ml urine per 24 hours. When there is no urine, urea is greater than 2.5 liters per 24 hours. Chemical exam. Presence of normal and abnormal chemical elements in the urine are detected using dry reagent strips. These plastic strips contain absorbent pads with various chemical reagents for determining a specific substance. Common chemical testing of urine utilizes commercial disposable test strip for glucose, bilirubin, ketone, specific gravity, Blood pH protein euro, bilinogen nitrite, and leukocyte stress. The result of this testing is evaluated as semi-quantitative procedure. Fresh urine specimen is collected in a clean, dry container, a multi-strip is briefly immersed in the urine specimen, covering all reagent areas. We did number 2. The issue of multi-strip is run against the rim of the urine container to remove excess urine. Strip is held in a horizontal position. Directions are read visually or automatically with a clean reflection photometer. The strip is evaluated visually. The strip test areas are compared to those on the multi-stitch color chart. At the specific times, the results are recorded and the strip is discarded. So this is chemical reaction chart. So from here, you can see for the layer of the image. Inside, nitrite, bilinogen, protein, pH, blood, gravity, tones, bilirubin, of course. This is our test compared the control intensity of the color from skin reading proportional to the amount of substance present. pH. The glomerular filtrate of blood plasma is usually acidified by renal tubules and collected ducts from pH of 7.4 to about 6 in the final urine. Depending on the acid base status urinary, which may range from as low as 4.5 to as high as 8. Clam pH indicates all sample or urinary tract infection. Exchange to acid side of 7.4 is accomplished in the distal coagulated tubule and the collecting duct. pH decline is a normal comparison. Specific gravity measures urine density or the ability of the kidney to concentrate or dilute the urine over that of plasma, which are available that also measure as in the approximation. Most laboratories measure specific gravity with a refractometer, say between 1.002 and 1.035 on a renal sample should be considered normal if kidney function is normal, since the SG of the glomerular filtrate in Bowman's space range from 1.007 to 1.010. The measurement below this range indicates hydration, and any measurement both indicate relative dehydration. If SG is not more than 1.022 after a 12-hour period without food or water, the mucosal is impaired. Generalized renal impairment, nephrogenic diabetes insipidus, and stage renal disease (ESRD) SG tends to become 1.007 to 1.010. SG is more than 1.035. Contamination with high levels of glucose. Intravenous high density radiofrequency dyes for radiography studies low molecular weight extrans solution. Subtract 0.004 for every 1% glucose to determine non-glucose solutes concentration. For the protein, the protein primarily detects protein called albumin, important indicator in the pH detection. Renal disease, semi-quantitative test for urine protein should be performed on the supernatant of centrifuge urine, since the cells suspended in normal urine can produce a falsely high estimation of protein. The small plasma protein filtered at the glomerulus are reabsorbed by the renal tubule. A small amount of filtered plasma protein and protein excretion by the nephron can be found in normal urine. Normal total protein excretion as 150 mg per day, or 10 mg for 100 ml in a single specimen. More than 150 mg per day is defined as for tenuria. More than 3.5 gram per 24 hours is severe and known as nephrotic syndrome. See detail. Protein by production of color with an indicated dye, brown or phenol blue, more sensitive to albumin, not sensitive to presence of globulins and burns Jones protein. Special Buah head is better quantitative method, but it is not a highly sensitive test. So the phosphoric acid test is a more sensitive precipitation test with albumin, globulins, and Baines Jones protein at low concentration. The result is negative 0 to 150 mg per 24 hours. First positive result, which represent a slightly haze appearance in urine, are equivalent to about 150 mg per 24 hours, upper limit of normal. 1 plus correspond to about 200 to 500 mg per day. 2 plus correspond to 0.5 to 1.5 gram per 24 hours. 3 plus correspond to 2 to 5 gram per 24 hours, and 4 plus represent 7 gram per 24 hours or greater. False positive, highly alkaline or highly buffered urine. For glucose, they appear in the urine at a plasma glucose of more than 10 millimole per liter by glycosuria. Excess sugar in urine generally mean the milliliters still employing the glucose oxidation for screening are specific for glucose, but can miss other reducing sugars such as galactose and fructose. For this reason, most newborn and infant urines are routinely screened for reducing sugar by methods other than glucose oxidase. The clinical test, the modified Benedict Cooper action test. False negative can result from megadose, vitamin C, tetracycline. The false positive trace 2 plus 1 can result from jar being left uncapped for a few days. Strong false positive will result in the presence of hypochlorite bleach. A positive glucose, you can see the first one. Ketones, stick to or test tablet containing sodium nitroprusside, ketones, acetone, acetoacetic acid, beta hydroxyuric acid resulting from diabetic ketosis or some other form of calorie deprivation or starvation. Negative blood, ketones, nitrite. The reagent stimulates nitrite by its reaction with N-azodide. A positive nitrite test indicates the bacteria may present in significant number in urine. The gram-negative routes such as E. coli are more likely to give a positive test. Leukocyte esterase. Positive leukocyte esterase test result from the presence of white blood cells either as wall cells or as light cell. Urea can be detected even if the urine sample contains damaged or lice WBC. Negative leukocyte esterase test means that an infection is unlikely and that without additional evidence of urinary tract infection, microscopic exam and our urine culture need not be done to rule out significant bacteriuria. Microscopic exam. Most commonly used procedure for the detection of renal and or urinary tract disease. Microscopic exam, we use that solid material suspended in the urine, both chemical and cellular, requires as well trained laboratory professional who is skilled in the use of various microscopic techniques such as bright field and phase microscopy, able to distinguish normal or contaminating items from normal pathologic elements. Knowledge variable of the clinical significance of each finding and its relationship to the chemical and physical analysis technique of microscopic examination of urine deposit. So if you have a sample of well-mixed urine, usually 10 to 15 ml, using a clean centrifuge tube at relatively low speed, about 2 to 3,000 RPM, for 5 to 10 minutes until a moderately cohesive button pellet is produced at the bottom of the tube of the splatter fluid during a deposit, and distilled in the bottom of the tube a volume of 0.2 to 0.5 ml. When it's left inside the tube, suspend the sediment in the remaining splatter by picking the bottom of the tube at a time. For a small amount, your exception. The suspended sediment onto a microscope, slide cover with rubber glass. Remain under the microscope. Microscopic exam. Variety of normal and abnormal cellular elements may be seen in urine sediments such as LVC, blue BC, mucus, various epithelial cells, cast, various crystal, bacteria. Down the low power to identify most crystal, cast, squamous cells at a large index, for example 5 to 10 line cast. As cast PF is made at high power. Identify crystal cells and bacteria. Report example 1 to 5 WBC per HPF. Artifact foreign substance has for human and domestic animals. There are fibers from blankets, bit of feathers, cotton fibers, starch granule of various sorts, steely, fatty or oily globules in a bubble. The microscopic exam, BC present of a few normal. It's normal, higher number are indicator of renal disease without bleeding, and a point in urinary system. And BBC are few normal, and may indicate inflammation or infection somewhere around the urinary or genital tract. Mucus like long, ribbon-like threads. Now finding urine, sediment secreted back, dense in the lower urinary tract. Epithelial cell, such as large and flat normal cells that line the urinary tract or renal tubules. Epithelial cells, in tubular epithelial cells is larger than granulocyte contained in a large number, round or oval nucleus in normally slouched in urine in small numbers, at least in condition nephrotic syndrome, leading to tubular degeneration. And epiduria occurs. The cell contain endogenous fats. When filled with numerous fat, the cells are walled. This are called oval fat bodies. Oval fat bodies exhibit a multi-scleral configuration by polarized light. Oval fat bodies consist of generated the cells containing abundant lipid which appears fat type. In the polarized light, oval fat bodies demonstrate their multi-scleral appearance. Transitional epithelial cells from the renal pelvis or bladder have more regular cell border. Large nuclei, a smaller overall size than squamous epithelium. Renal tubular epithelial cells are smaller and rounder than transitional epithelium, and near nucleus occupies more of the total cell volume. Squamous epithelial cells from the skin surface around the outer urethra can appear in urine. The significance is that they represent possible contamination with the specimen with skin flora. Urinary gas formed in the distal convoluted tubal BCT or collecting duct. Distal nephron, the proximal convoluted tubal BCT and low of L. Another location for gas formation having gas composed primarily of mucoprotein, thumb phosphol protein secreted by tubular cells. Gas. These gas are formed as a still convoluted tubal BCT or the collecting duct. detailed nephron. The cast are composed primarily of mucoprotein, term phosphoprotein secreted by tubule cells. The term phosphoprotein secretion green dot is illustrated in the diagram above, forming a hairline cast in the tindak. This is epithelial cell cast, cellular and granular cast, coarse granular cast, fine granular cast. Last one is waxy cast. It's complete illustration of transition between epithelial cell, coarse granular, and waxy cast formed in loop of health. Tubule and ducts, blue area of nephron in upper right hand corner. Even with glomerular injury causing increased glomerular permeability to plasma proteins with resulting proteinuria, most metric or glue that Siemens in the cast together is term phosphor mucoprotein, although albumin and some albumin are also incorporated. An example of glomerular inflammation with leakage of RBCs to produce a red blood cell cast is shown in the diagram. Factor favoring protein cast formation are low flow rate, excess subinteraction, and low pH, all of which favor protein denaturation and precipitation, particularly that of B term phosphol protein. Protein cast with long thin tails form at the junction of Helms loop and the distal convoluted tubule are called silene rods. The cast can be seen even in healthy patients. Cast which appear very pale and slightly refractile, a common finding in urine. RBC may stick together and form red blood cell cast, indicative of glomerulonephritis. With leakage of RBC from glomeruli or severe tubular damage is present of this red blood cell cast in urine. Microscopic analysis suggests a glomerular or renal tubular injury. White blood cell casts are most typical for acute pyelonephritis, but they may also be present with glomerulonephritis. Indicates perforation of the kidney because of casts will not form except in kidney. Also, casts remain in the nephron for some time before they are flushed into bladder urine. The cells may be degenerated to become a coarsely granular cast, later a finely granular cast, and ultimately a waxy cast. Granular and waxy casts are believed to derive from venotubular cell casts. Broad casts are believed to emanate from damaged and dilated tubules and are therefore seen in stage chronic renal disease. Casts which persist may break down, so that the cells forming it are degenerated into granular debris, as has occurred in this granular cast. This is a broad waxy cast, not that the edges are sharp and there are cracks in this cast. The so-called telescope sediment is one in which the cell cells overproduce and all types of casts are found in more or less equal proportion. The conditions which may lead to telescope sediment are: first is lupus nephritis, second is malignant hypertension, 3 diabetic glomerulosclerosis, and rapidly progressive glomerulonephritis. And stage kidney disease finally cause injury sediment often become very scant because few remaining nephrons produce dilute urine. Bacteria are common in urine specimen because of the abundant number of microbial flora of the vagina, external urethral mucus, and because of their ability to rapidly multiply in urine standing at room temperature. Therefore, microbial organisms found in all but the most scrupulously collected urines shall be interpreted in view of clinical symptoms such as of bacteriuria. In the case of suspected urinary tract infection requires culture. The urine count may also be done to see if significant number of bacteria present. Generally, more than 100,000 ml of one organism reflects significant bacteriuria. Multiple organisms reflect contamination. The presence of any organism in characterized or suprapubic depth specimen should be considered significant. Yes, cells may be contaminants or represent a true yeast infection. They are often difficult to distinguish from red cells and amorphous crystal, but are distinguished by their tendency to bud. Most often, they are candida, which may colonize bladder, urethra, or vagina. These cells appear most round or ovoid gauze, often with small cells budding off a larger cell. They are slightly smaller than erythrocyte, one of which can be seen to the right of center in this image. The crystal. Common crystals seen even in healthy patients include calcium oxalate, triple phosphate crystal, and amorphous phosphates. Calcium oxalate, the hydrate crystal look like little envelope or tetrahedrals, depending upon your point of view. So the crystals are common calcium oxalate monohydrates, crystal spindle, oval or dumbbell shape. Commonly they appear as flat, elongated side fence picket crystal as seen at the right, and that they closely resemble colorless ABCs. The phosphate strovite magnesium ammonium phosphate crystals usually appear as colors prism-like coffin beads. They are often seen in urine from clinically normal individuals, though they can be found in urine of any pH. Their formation is favored in ureterotracheal urine. Urinary tract infection with urease producing bacteria, Proteus vulgaris, promotes strovite crystallaria and urolithiasis, raising urine pH and increasing the ammonia. The uncommon crystals include cysteine, leucine, tyrosine. Distinct crystals are seen as flat, colorless, hexagonal plates. They often integrate in layer. Their formation is favored in acidic urine. Leucine crystals are seen as yellow sphere with concentric and radial striations. This crystal can sometimes be mistaken for cell, with the center resembling a nucleus. In the polarized light, leucine crystals transmit a multi-cross interference pattern. Distinct crystal in urine of neonates with congenital listeria, normal error of metabolism, or severe liver disease. Leucine crystal in patients with severe liver disease or maple syrup urine disease. Leucine crystal with congenital tyrosinosis or marked liver impairment. Crystals are usually seen as fine brownish needle, either isolated or as rosette. They are sometimes associated with severe liver disease. Summary. Properly collected killing cash mixed during urine after cleansing of the urethral meatus is adequate for complete urinalysis. The specimens generally suffice even for urine culture. A period of dehydration may visit urine if testing of renal solution is desired, but specific gravity more than 1.022 measured in a randomly collected specimen denotes adequate renal concentration so long as there are no abnormal solids in the urine. Another important factor is the interval of time which elapsed from collection to elimination in the urine in the lab. Changes which occur with time after collection include increased clarity due to crystallization of solutes, rising pH, loss of ketone bodies, loss of bilirubin, solution, cell cast, and overgrowth of contaminating organism. Generally, urinalysis may not reflect the finding of absolutely fresh urine if the sample is more than 1 hour old. Therefore, get the urine to the lab as quick as possible. This is in an important clinical diagnostic test. This can reveal diseases that have gone unnoticed because they do not produce striking signs or symptoms. This provides information about the kidney, urinary tract, and systemic kidney disorders. The result of the microscopic chemical and microscopic analysis must be interpreted together to arrive at a proper diagnosis. Although analysis is easily performed with reagent test strip, the results are dependent on correct technique and understanding of the limitations and interference those technologies and technicians perform, meaning the test must be properly trained, especially in correcting recognized microscopic element. Okay, then we go to chapter 2.